Hi, this is Dr. Vallesh. Welcome to Pharmacology Simplified. In this video, I am going to give an overview of Angina Pectoris. I am going to speak about the pathophysiology of different types of Angina Pectoris with the principles of the management of different types of Angina Pectoris. I am not going to cover different anti-anginal drugs in detail in this video. They will be covered in different videos. This topic is important for your theory exam, practical exam, especially prescription writing exercises, viva, and of course your entrance exams. Angina pectoris as such, it is derived from a Greek word called anko. It means strangling or throttling or choking. And pectoris, you would have learned from your anatomy lessons, pectoris means pectoral region, chest region. So angina pectoris as such means strangling type of sensation in the chest region. If you ask the history of a patient who has angina pectoris very carefully, he will not complain of pain, he will complain of substernal discomfort, as if a heavy weight is placed on his chest, as if somebody is sitting on his chest. So there is rarely pain, it is actually substernal discomfort, and there is characteristic radiation of this discomfort from the chest region to the left arm, ulnar border of the left hand, left lower jaw and back. If all these symptoms are present, most likely that the patient is having angina pectoris. Remember, angina pectoris is not a disease, it is a symptom. It is a symptomatic manifestation of some underlying condition. What underlying condition is there? Why this angina develops? Angina develops as a symptomatic expression of myocardial ischemia. There is ischemia that is going on, the blood supply to the myocardium has become affected, and because of that the heart is providing a warning signal in the form of angina pectoris. So remember, angina pectoris is not the disease, it is a symptom. The disease is there in the heart. More specifically, the disease is there in the coronary arteries which are supplying to the myocardium of the heart. You should treat this condition, you should treat the underlying condition. Now the principles of management of angina all depend on two things. One is oxygen demand, second one is oxygen supply. Whenever you are trying to manage angina pectoris, you have to remember these two words, myocardial oxygen demand, myocardial oxygen supply. The myocardial oxygen demand is determined by factors such as heart rate, contractility, preload, afterload. If there is higher heart rate, higher force of contraction, higher contractility, oxygen demand will go up. If the preload is high, the amount of blood returning to the heart is more, or if the afterload is high, that is the arterial pressure is more, the work of the heart increases. The work of the heart increases, the myocardial oxygen demand is going to increase. On the other hand, oxygen supply to the myocardium is done by coronary arteries, and there are two aspects there. One is the blood flow in the coronaries, in the larger part of the artery, and second one is the blood flow in the smaller arterioles that are branching out of the coronary artery. That is called the regional myocardial blood flow. Both of these are essential so that oxygen supply and oxygen demand are in a balance. So how much oxygen the heart wants, the myocardium wants, the coronaries and the arterioles should supply the same amount of oxygen in the form of blood. So if there is balance between oxygen demand and oxygen supply, everything is all right. But if there is an imbalance, that will lead to ischemia. So if there is increased demand or if there is decreased supply or both, that will lead to ischemia, and later on it will lead to infarction. So what are all factors which lead to increase in myocardial oxygen demand? If there is increased heart work, such as increased heart rate, increased force of contraction, the patient is having high arterial blood pressure, and if the heart is working against a high arterial blood pressure, if there is structural abnormalities of the heart, all these conditions, and if there is sympathetic overactivity due to stress, exertion, all these conditions, the heart work is increased, the heart will have to work more. In those cases, myocardial oxygen demand increases. And supply, what are all conditions where the supply, myocardial oxygen supply or myocardial blood flow is decreased? There should be some sort of obstruction in the coronary arteries. This obstruction is mainly brought about by three factors. One is plaque, atherosclerotic plaque. Second one is thrombus. The third one, if there is vasospasm. So all the factors leading to increased work, increased myocardial work, are precipitating factors for the patient to develop angina. in the setting of these precipitating factors, if there is a condition where the coronary artery is blocked, that will lead to angina pectoris. This is the basic pathophysiology behind development of angina pectoris. Now let us dissect it much further. We have seen that the blockade of coronary artery can happen through three main reasons. One is a plaque, other one is thrombus, and third one is vasospasm. Let us look at it in more detail. This is normal coronary artery, cross section of a normal coronary artery. It has no plaque, no thrombus, nothing. Blood flow is normal in this. If there is a plaque, what is happening? The blood flow is reduced. If there is a plaque and thrombus, what is happening? Again the blood flow is reduced. And if there is vasospasm, again the blood flow is reduced. So all these are the three main reasons for a reduction in myocardial oxygen supply, myocardial blood supply and oxygen supply as well. These are the three major types of blockade of blood supply. And if the blood supply blockade is because of plaque only, the angina that develops is called as classical angina. It has certain other synonyms: typical angina, stable angina, exertional angina. If the blockade is because of plaque and thrombus, it is called as unstable angina. It is very easy to remember. See, the thrombus is unstable, right? It has a tendency of developing into an embolus. It will not stay in one place, whereas plaque is stable. It will stay in one place, whereas thrombus can get dislodged and become embolized, move to other places. It is unstable. So the angina that develops because of plaque and thrombus is unstable angina. It is also called as crescendo angina. It is also called as pre-infarction angina. The pre-infarction angina, because if the thrombus continues to evolve, continues to become larger, it will lead to complete blockade of coronary blood supply, and that will lead to infarction. So pre-infarction angina is another name for unstable angina because that can lead to infarction. The third type, if there is vasospasm, the coronary artery blood supply blockade is because of vasospasm, that type of angina is called as variant or vasospastic or Prinzmetal angina. This is the rarest of the three. Most common type of angina is the first one, that is developing due to a plaque, or classical angina, typical stable angina. That is the most common type. Rarest is the third one. So what about the second one? There has to be an adjective for the second one as well. First one, classical angina, is the commonest. Third one, variant, is the rarest. Second one is the most dangerous type of angina. There is something called as ACS, acute coronary syndrome. Three conditions are classified under acute coronary syndrome. One is STEMI, ST elevation myocardial infarction. Second one is non-ST elevation myocardial infarction, NSTEMI. Any idea which is the third one? The third one is unstable angina. So unstable angina has been grouped along with myocardial infarction. That is the reason why unstable angina is the most dangerous type of angina. Moving on, how do you manage different types of angina? You now know the pathophysiology behind each type of angina. You now know that in angina there are two things. One is oxygen demand, and the second one is oxygen supply. If you have to manage case of angina, you have to either decrease the demand or you have to increase the supply. Out of these two, decreasing the demand is only a temporary solution, because the pathology is because of this. The supply is reduced. That is the basic pathology. So if you have to provide a proper answer, proper solution to the patient who is suffering from angina, this is supposed to be the key. That is, increasing the supply is supposed to be the key. So strictly speaking, decreasing the demand is only a stopgap measure, almost a symptomatic, whereas increasing the supply is the definitive solution for the management of angina. So all anginas, the first management principle is to resolve the acute attack. The patient will present with substernal discomfort. Your first priority is to resolve the acute attack, and for doing that, you have to give sublingual nitrates. These are the drug of choice for resolving acute attack. Next, for the time being, till you can figure out how you can improve the myocardial oxygen supply, you have to reduce the myocardial oxygen demand. And for doing that, you can use three groups of drugs: nitrates, beta blockers, and calcium channel blockers. You can use these three especially nitrates and calcium channel blockers for all the three types of angina. But beta blockers have put a star there, and the reason for that is you cannot use beta blockers for the management of vasospastic angina. You cannot use beta blockers to reduce myocardial oxygen demand if the patient is having vasospastic angina. The reason for that is beta blockers, especially non-specific beta blockers, which block both beta 1 receptors and beta 2 receptors, block the beta 2 receptors that are located on the coronary arteries. Beta 2 receptor activation in the coronary artery is responsible for vasodilatation. If these beta 2 receptors are blocked, there will be vasoconstriction. Already the patient is having vasospasm. That is the pathology behind vasospastic angina. If the patient is having vasospastic angina, should not use beta blockers for the same. Understood? So this is the management principle that is applicable for all types of angina. Next, let us look at stable angina. As I told you, the definitive answer is to increase the myocardial oxygen supply, and you can do that in stable angina by dissolving the plaque. And what is this plaque composed of? That plaque is made up of atherosclerotic material. It is atherosclerotic plaque. So if you want to dissolve that, you have to use statins, and you have to advise lifestyle modifications. Next, plaque is there. There is high chance that the plaque, the endothelium covering the plaque is going to open up, leading to the formation of thrombus. You should prevent the development of thrombus in the patient who is having plaque already, in the patient who is having stable angina. How do you do that? You do that by giving antiplatelet drugs such as aspirin and clopidogrel. This is the management principles for stable angina. Next is unstable angina. The most dangerous variant of angina is unstable angina. So what is the management principle there? On a priority, you should remove this thrombus. You should make sure that this thrombus does not evolve, or the thrombus does not get dislodged and become embolus. So that is the priority management principle there. Increase oxygen supply by immediately removing the thrombus, and for that no drug is effective. You have to go for intervention, PCI, percutaneous coronary intervention, or CABG, coronary artery bypass grafting. And that is the reason why unstable angina has been placed under the category of ACS. Finally, vasospastic angina. How do you increase the oxygen supply? By relieving vasospasm. You have to give certain vasodilators which will relieve the vasospasm. Which vasodilators are these? These are nitrates and calcium channel blockers. Again, you cannot use beta blockers here because beta blockers will produce vasoconstriction. So remember that beta blockers are contraindicated in vasospastic angina. So I hope I have been able to simplify this topic for you. Thank you. Namaste. Have a nice day.